So I'm the medical director of the Epilepsy Monitoring Unit at Anschutz Medical Campus, and also the director of epilepsy surgery. So I'll be talking about lots of treatment options for epilepsy, ranging from medication and non-medication options. So to outline the talk, I'll be starting with definitions and specifically how we define epileptic seizures, epilepsy, and how specifically we define medication resistance. I'm going to talk about what makes a comprehensive epilepsy center and what we may expect from a comprehensive epilepsy center. I'll go into phase 1 and phase 2 monitoring and discuss advanced surgical options that may be offered at a comprehensive epilepsy center. I'll discuss non-surgical options, and then we'll have time for some questions. So to begin, what is an epileptic seizure? And epileptic seizures are symptoms that are caused by abnormal and excessive electrical activity of nerve cells. So these cells are located in the outer layer of the brain that is called the cortex. It's also gray matter. So during a seizure, there's an imbalance in electrical impulses that leads to excess excitation or excitatory electrical activity that manifests in a seizure. So seizures can occur also as a result of sudden changes within the brain due to triggers, such as alcohol, drugs, and injury, also abnormal blood sugar or electrolyte imbalances. These seizures are referred to as provoked seizures. And often no medical treatment long-term is necessary, as it is sufficient to remove the trigger. So to be distinguished from having a long-term predisposition or epilepsy. So epilepsy is the 4th most common neurological disorder and affects people of all ages. Most commonly occurs in very young or a more elderly population. So we call this a more bimodal distribution. If seizures occur repeatedly without provocation, we say a person has a seizure disorder or has epilepsy. These are one and the same. Epilepsy means having chronic or recurrent unprovoked seizures. So the word epilepsy does not indicate anything about the cause of a person's seizures or does not indicate anything about the person's seizure severity. Therefore, we also call epilepsy a spectrum. So this means that there are many seizure types, and the control of a person's seizure may vary, varies from one person to another. So medications are the mainstay for controlling seizures. So here's a graphical depiction of development of anti-seizure drugs from 1840 to the present time. And starting with bromide, and then subsequently barbiturates, phenobarbital, phenytoin, primidone, carbamazepine, sodium valproate. So these several medications we refer to sometimes as first generation anti-seizure medications that take us through about 1980. Then you'll see that there's this rapid escalation in addition of anti-seizure medications in the 80s and early 2000s with addition of zonisamide, felmamate, lamotrigine, topiramate, oxcarbazepine, levetiracetam, your so-called second generation anti-seizure medications. And then yet another addition of a series of anti-seizure medications with pregabalin, and of course I'm using generic medication terms, lacosamide, stiripentol, rafinamide, retigabine, no longer on market, perampanel, brevtiracetam, and then so-called third, and even then your third/4th generation with cannabidiol, cenobamate, and then these last couple are for acute repetitive seizures. But suffice to say that we have in the last 20 years have made a significant drug development and brought drug to market, especially with regard to new mechanism of action and so forth. So brings me to the next knew that was going to happen slide, which is medication-resistant epilepsy. So there are about 3.5 million Americans in the United Americans with epilepsy, and 800,000 of which have medication-resistant epilepsy. So what does that mean? It means that the person continues to have seizures despite taking despite trials of two appropriately prescribed medications that have been have adequate trials, so that we're not discontinued for adverse side effect and so forth. Now, after these adequate trials of two medications, the success rate of subsequent medication controlling seizures is actually less than 5%. So the pivotal trial was one that you may have heard of before, is the Th1nk and Brody study, the first of which was published in 2000 and has been subsequently repeated by the same group and by others. But in essence, the first medication has been shown to control seizures in about 50% or half of the time. So you basically can flip a coin and 50% of the time seizures will be controlled. With the second medication, either alone or in combination with the first medicine, will add approximately 15% additional seizure control. So you add a third medication or subsequent trials of medication, there may be an additional 5% or so, and then you're left with about a third of people that are pharmacoresistant. Interestingly, this has not improved in the last 30 years, and this is, you may remember the 30 years that we have seen this advent of medication development. And so despite this, we have not really made much of a progress in terms of pharmacoresistance. So we've remained in about the 60 to 65% range. So this is the same cohort of patients that have been followed longitudinally over time. So beginning in 1982, and you can see that this N is this number of patients added to this group, and the rate of seizure freedom is the same. So we really have this similar group of resistant or medication resistant patients. So how does this differ in different types of epilepsy? So in partial onset or focal onset seizures, these are seizures that start in one part of the brain. The electrical discharge may start in one area and move to involve other structures that are nearby, or may involve the entire brain. But the important point is that it starts in one focus. And so in partial onset seizures, this comprises about 2/3 of drug-resistant patients. In contrast, generalized onset seizures begin with a widespread electrical discharge that involves the entire brain from the onset. And generalized onset seizures comprise about 1/3 of drug-resistant patients. So having focal onset or generalized onset seizures does not necessarily tell you what the seizure looks like on the outside, but may confer some, in terms of a medication resistance, may confer something prognostically. So shifting to goals of treatment, and bottom line, it boils down to enhancing quality of life. And for some, that means eliminating all seizures. For some, that means minimizing medication-related side effects, or in some that means completely getting rid of medications if possible. How do seizures impact relationships and self-esteem? How seizures impacts mood, or simply sometimes depression actually precedes the diagnosis of epilepsy. Limitations that seizures have on employment, education, finances, limitations on driving and transportation, worry about having the next seizure and not being able to predict where or when that may occur, and misperceptions of epilepsy. And this is a very short list, and it goes on. So what is an epilepsy center? It's a center that specializes in the diagnosis and treatment for patients with epilepsy and seizure disorders, with a comprehensive team approach of epileptologists, so neurologists that are board certified in epilepsy and treatment of patients with seizure disorders, epilepsy surgeons, neuropsychologists, neuroradiologists, epilepsy nurses, psychiatrists, EEG technologists, and more. So what is the advantage of going to an epilepsy center? What might you learn in an epilepsy center? So the first is to get some answers. It's astounding that about 30% of people sent to a comprehensive epilepsy center for so-called uncontrolled seizures find out that they were misdiagnosed. Another reason would be medication management. So in many cases, perhaps the epilepsy diagnosis is correct, but maybe the medication regimen is not appropriate for that particular person or that particular person's type of epilepsy. Also, to obtain a full range of treatment options for medication-resistant epilepsy, such as a variety of epilepsy surgeries or neurostimulation devices. So going a little bit more in depth, so epilepsy monitoring, I'm going to talk about phase 1 and phase 2 monitoring, also specialized types of EEG, MEG and tilt are a couple. I talked about surgical options, but specifically the VNS, RNS, and DBS devices, and laser ablation, and then specialty clinics. So those that include diet clinics, clinics for neurofeedback, those for people that may suffer from neurocutaneous syndromes, and also for women with epilepsy that desire pregnancy or who are pregnant. Also seizures, clinics for patients with non-epileptic seizures, and also the ability to be involved in clinical trials. So I'm going to shift gears into phase 1 and phase 2 monitoring. So phase 1 evaluation would be the most basic form of evaluation in terms of determining what, where, and I guess learning more about the patient's seizures. So the patient is electively admitted with video and EEG, while seizures are what we say is captured in a real-time fashion. And so why would we do this? So in some cases, there's a question as, is a certain movement or a behavior or a sensation, is it a seizure or is it not a seizure? So that's what we refer to as a characterization. Localization is, well, if it's a seizure, then where is it coming from? And we may want to determine if it's coming from one specific location, more than one location, or if there's potentially a seizure that's coming from, as we refer to, generalized onset, if it's beginning, if the electrical activity is widespread. And less commonly, patients are admitted for medication adjustment. So here's an example of a scalp EEG. These are placed by the EEG technologist in a very specific way that scalp is measured, and you can see that the activity on the upper part of the screen looks a little bit different about, I don't know, the last third, and that's actually an example of a focal onset seizure. So we can correlate that with a patient's symptoms, behavior on video, and then try to determine where that seizure may be originating from. So intracranial, or often referred to as phase 2 monitoring, may be performed in a selected group of patients, or may be recommended to guide epilepsy surgery if the seizure onset is not clear, or when the MRI does not show a lesion. And sometimes that's referred to as so-called lesional epilepsy. So prior to the phase 2 monitoring, the patient would complete a comprehensive pre-surgical evaluation that is presented to the epilepsy team during a multidisciplinary surgical case conference. So we get together as a group of epileptologists, surgeons, radiologists, and discuss all of the imaging, EEG findings, and so forth, and then we determine the best approach for the patient. The phase 2 monitoring refers to the monitoring that's done with the electrodes placed inside the skull by the neurosurgeon. It's done in the operating room under general anesthesia. And these may be within the brain with depth electrodes, or on the surface of the brain with grid and strip electrodes. So have some depictions for you here. So we have a hypothesis based on all the pre-surgical evaluation as to where the seizures are originating from. And then we have a stereotactic guided MRI placement of electrodes that are done if on the left side of the screen, these are depth electrodes. They are actually inserted in very tiny holes and done to strategically avoid structures like blood vessels. And the patient then returns to the epilepsy monitoring unit just as they had for their phase 1 procedure for seizure monitoring. So seizures are then obtained again in the epilepsy monitoring unit with these electrodes in place. On the right side is a pretty extensive representation of a patient who has a grids and a strip electrodes that are placed on the surface of the brain. So in contrast to the first seizure that I showed you, where there was only about 16 lines on the screen, we may have an array of hundreds of lines to look at and have to kind of reconstruct that spatially to determine where the seizure is originating. So this is an example of a seizure beginning in a phase 2 intracranial study, and you can see that that's this kind of jagged appearance in the middle of the screen is the seizure onset. So I'm going to talk about what may this lead to. So in a patient who has surgical options, where may they go? So does every patient need a phase 2? No, they don't. Some patients may require a phase 2 to have options such as ablative or resective surgery, or even RNS. But there are many surgical options that were not available even 3 years ago. So neurostimulation is an alternative so-called surgical option. About 10 to 20% of patients with medication-resistant epilepsy are good candidates for resective or ablative surgery, but what about those that are not? So there's a vagus nerve, responsive nerve, and deep brain stimulation. So the vagus nerve stimulator, or VNS, is a device that is placed in the chest wall on the left side, typically under the pectoralis muscle, and there is a coil that is placed around the vagus nerve in the neck. And that is done in an outpatient procedure. The patient typically goes home on that same day. The VNS settings are, depending on the device, they're typically increased about every 2 to 4 weeks for approximately 6 visits. There are some models that can auto-titrate or automatically increase their settings on a programmed basis, but traditionally, patients come into the office for reprogramming. About 5% of patients may become seizure-free, but by far and large, people report that it reduces seizure frequency and seizure severity, so it's a palliative option. It can also be used to help interrupt seizures. So there's a magnet that is provided with the device. The magnet is swiped over the device to deliver a stronger stimulation that may last longer, and that can then help interrupt the seizure. So this is a meta-analysis, so a pooled analysis of randomized controlled trials and some retrospective and prospective studies, and suggests that VNS may be more effective in generalized seizures than in focal seizure types. And so looking at what one may expect in terms of a decrease in seizure frequency by seizure type. And this is the number of patients in partial mixed seizure types, so maybe with some partial and generalized features, and then those with generalized onset. And so in terms of seizure reduction in partial was 43% with about 500 patients, and about 58% seizure reduction, and up just over 100 patients with generalized onset seizures, and somewhere in the middle with mixed seizure types. So moving on to the next device is a deep brain stimulation. This is the newest therapy, I would note, for epilepsy, but not for movement disorders. So deep brain stimulation is a small pacemaker-like device. It's placed in the chest similarly to the vagus nerve stimulator. However, much differently than the vagus nerve stimulator, there are electrodes that are placed in a deep part of the brain called the thalamus. This was approved for treatment of epilepsy in the United States in 2018. For movement disorders, it was for treatment of tremor related to Parkinson's or essential tremor. It actually was approved in the late 90s. So we're far behind in epilepsy in terms of DBS. How does it work? It modulates seizures by delivering intermittent stimulation. Rarely there's continuous stimulation, but I would say that it's traditionally delivers intermittent stimulation to the thalamus, which is involved in seizure propagation. So it interrupts this network. So what one anticipate in terms of results with a DBS? So we often refer to responder rate when we talk about clinical trials, and the responder rate is defined as a percent in seizure reduction. So this is a 50% or greater seizure reduction. And at 1 year, the responder rate of 50% was 43% of patients had a 50% or greater seizure reduction. This improved over time. At year 7, it was 74%. Important to note, however, that the number of patients over time also decreased. How that may affect the results, I'm not quite sure, but over time, the responder rate of greater than 50% did increase. So moving on to the responsive nerve stimulation. So this is called closed loop, meaning that there's ability to detect and respond within the same device. This is a device where as opposed to the vagus nerve and the deep brain stimulator where the battery is in the chest, this one is actually in the skull. With the electrodes that are detecting placed where the seizures are believed to originate from. So that's either through phase 2 monitoring, or if the patient may have a lesion that's contributing to their seizures, may be placed within or on top of the lesion. There's the patient is equipped with a computer. It's called the remote monitor to download the data from their stimulator. So they have to put this device over their head to download this data that is then shared with their physician, who can review the data on an intermittent basis and reprogram the device. Oops, hold on a second. All right, so what are the results with the RNS system? So seizure frequency improves over time. So at 1 year, the median seizure reduction is about 67%, and at 3 years, about 82%. The post-approval study, which is a cohort of patients that were treated as a standard of care, was 39% of patients had at least one period of greater than 6 months of seizure freedom. So again, this is this closed loop here is referring to this monitoring of brain activity continuously, detecting patient-specific patterns, and then automatically stimulating in response to these patterns. This is an example of a RNS in one of my patients with cortical strip leads that are these little white dots that are placed. This is the generator in blue. And so this is kind of depicted here. And this white part, this is the underside of the temporal lobe. So these are placed on the temporal lobe surface. And you can see how over time, this is at 4 years, this patient has had a greater than 90% seizure reduction post-implantation. And so you're able to really get an idea visually how the patient is doing and how you're doing if you have an RNS device in your clinic visits. Laser surgery is a newer type of surgery that is much less invasive than previously was only available was an open temporal lobectomy with an open craniotomy, with a patient would have a large skull defect and would be much longer recovery time. Now the surgeon is able to guide the catheter in an occipital approach that goes through the back of the skull, and then this catheter tip is heated, and you can see that this structure, this area that is colored here, is actually in a part of the brain called the hippocampus that is often used. This approach is often used for hippocampal or ablations. So it's a newer and minimally invasive surgical technique for patients who have small, about 2 centimeter lesions that cause seizures. So similar to the depth electrode approach, that's stereotactic, meaning that we use a guidance system through a small hole, and the laser tip is placed in the middle of the target area. And the amount of energy transferred is monitored by the MRI to allow precise control of the laser. The destruction of the lesion by heat is called thermal ablation. And because there's only a small surgical wound, there's less risk, and the length of stay is reduced. Patients may go home in 1 to 2 days. Open resection is still sometimes offered to patients because we feel, again, like the area that is needed to be removed is much larger, that the seizure network that is involved would not be easily served by when the patient would continue to have seizures despite, for example, a laser ablation. So this is an example again of this is a temporal lobectomy. You can see that as opposed to the laser ablation with this tiny catheter tip, the surgeon actually drills holes, removes a bone flap, and then there's a much larger cavity of a resection. You can see at the top that is filled with cerebrospinal fluid after that tissue is removed. So moving from all the heavy surgical stuff into dietary options. So what are some dietary treatments for epilepsy? These treatments include groups of dietary regimens with significant carbohydrate restriction and generous fat intake. That's the kind of outline of them. They're often referred to as the ketogenic diets. There's the standard ketogenic diet, which is typically used in the pediatric populations, the modified Atkins diet, and then the low glycemic index diet. So here's a comparison compared to the standard diet, where we may have about 50% carbohydrate, 35% fat, and 15% protein. So the ketogenic diet on the far left, again, mostly used in pediatrics, is about 90% fat, and then with about 8% protein and then 2% carbohydrates. So not a whole lot in the diet other than fat. The modified Atkins diet is referred to as modified because it's not used for weight loss where it was originally designed. But again, here fat is about 64%, protein 30%, and carbohydrate 6%. So it's about 20 grams of carbohydrate a day. And then the low glycemic index has a little bit more carbohydrate exchanged for the fat. So 60% fat and 10% carbohydrate. Since we're in Colorado, I feel like we must talk about cannabis. And so cannabis, interestingly, was first used in the 19th century as an anticonvulsant. There are cannabinoid receptors in the brainstem, the limbic system, and the cortex. However, there are many mixed results in terms of the types of cannabinoid. THC has either anti or proconvulsant effect depending on the dosing and the animal model. So there are many cannabinoids with variable effects, and also to mention that there may be potentially negative health consequence with regard to other organ systems, and also has been raised for the concern for withdrawal seizures. Cannabis cannot be prescribed except for states with medical cannabis. So Epidiolex would be the medication that is purely purified CBD extracted from plants, which is nearly 100%. FDA approved for Dravet, Gastaut syndrome, and then also for tuberous sclerosis-related epilepsy. It's dosed per weight. It's important to note that there may be medication interactions with Epidiolex. A recent study that we conducted, a survey at the University of Colorado, was actually quite eye-opening for me anyway. About 50% of our patients reported non-prescribed cannabis use. And this was actually much higher in patients with drug-resistant epilepsy. Of those reporting cannabis use within the last 12 months, a majority believed that it had a beneficial effect on seizures, not necessarily just seizure frequency, but many other effects surrounding seizures, for example, post-ictal symptoms, headache, and so forth. Interestingly, there was no correlation with any quality of life measure. So despite the fact that patients reported having improvement with regard to seizures, they did not report necessarily that they had an improvement in their quality of life. And so last thing that I think is very important to emphasize when navigating this medication-resistant world, I think it's always important to know that to be your own advocate and also to look at the Epilepsy Foundation and others for guidance. But if you are suffering from seizures, despite medications, prior surgery, or having a vagus nerve stimulator, find your way to a comprehensive epilepsy center for an evaluation. There is an organization called the National Association of Epilepsy Centers, and there are several epilepsy centers around, the Denver metro area. So I think, this is a very important advocacy piece in order to get the correct epilepsy care management. So thank you.